not have any conflict in many of the issues that I am going to discuss with you. The first question is that when there are topics that are much more sexier than corneal ulcer, why are we talking about corneal ulcer? Anyone? I think as a clinician, as an ophthalmologist, you cannot get away by ignoring or by not knowing the management of corneal ulcer, because we what is the role of microbiology workup, and then we will also try to address some of the recent aspects that are affecting the management of corneal ulcer as compared to the traditional teaching, and we'll try to use cases as examples in order to understand these. Okay, one of the basic premise in the management of corneal ulcer is that you have to institute intensive therapy with appropriate antimicrobial agents. Now here the appropriate antimicrobial is the crux. The question is, how do you determine what is the appropriate therapy? The appropriate therapy can only be known if you know what is causing the corneal infection. Can you do it clinically?
Prashant Garg. No, she wants to know your name.
Probably yes. There is a way in which you can create a differential diagnosis. If you are dealing with a case which is kind of a rapidly progressive, characterized by a suppurative infiltrate, you can make an impression that you are dealing with a virulent microorganism. And what are the virulent microorganisms? These are usually bacteria such as Staph aureus, Strep pneumoniae, Pseudomonas aeruginosa. At times, even the mixed infection can present with the clinical picture of a rapidly progressive disease. However, if you are dealing with the slowly progressive disease with the localized infiltrate, it is more likely to be a low virulent pathogen. Which are the low virulent pathogens? Fungi, parasites, and some of the bacteria such as nocardia, atypical mycobacteria, Staph epidermidis, Corynebacterium. So these are the group of organisms that should come in the differential diagnosis if you have a history in weeks or months. Now there are certain characteristic clinical features that can also lead you to the what kind of disease you are dealing with. If you see this picture, it is a very well localized infiltrate, well defined edges, and if the history is relatively acute, probably gram-positive infection must be the differential diagnosis. If you are seeing a very well ill-defined border with intense reaction in the surrounding cornea or severe anterior chamber reaction, extensive suppuration, then your first differential diagnosis will become gram-negative bacteria. If you are seeing this kind of a pinhead-sized lesions which are arranged in a wreath pattern, then you will think about nocardia. If you are having a raised lesion which is dry cotton wool-like with the filamentous extension into surrounding cornea with or without pigmentation, obviously the first differential diagnosis will be fungal infection. And if you are dealing with a ring-shaped infiltrate, then acanthamoeba will be your first difference. So these are the characteristic clinical signs that you can take into account after constructing a differential diagnosis list in further narrowing down your diagnosis. Now question is, how sure are we when we deal with these characteristic clinical features as, no, I am very sure that this is going to be my correct diagnosis. Now, I'll just give you an example. You are seeing two pictures of patient who presented with a ring infiltrate. Now, what will be your first differential diagnosis? Acanthamoeba. But the ring infiltrate is also described in fungi. Ring infiltrates are also seen in Pseudomonas infection. So here, that dilemma starts coming in. So, like you said that you will suspect acanthamoeba as your first differential diagnosis. A resident who was rotating with me also suspected acanthamoeba. We did corneal scraping and found it to be of fungal etiology. Now this argument is not just among clinicians here. people who were working extensively on corneal infection once thought that fungal keratitis usually present with a very characteristic clinical feature. And therefore, if you see that picture, you should be able to start antifungal treatment. They said, let us see in community when you practice, how many percentage of the cases you are able to make the correct diagnosis based on those characteristic clinical pictures that has been described in the literature. Now, what was the finding of that study? People who had experience of 10 years in handling these cases made wrong diagnosis 30% of the time. That is, the clinical diagnosis was not correlating with the microbiological diagnosis, and they concluded that in all these patients of corneal infiltrate with suppuration, microbiology is the best way to direct your therapy. Now, what does microbiology comprises of? You need to take corneal scraping using 15 number surgical blade. And once you have taken scrapings, use various culture media as well as microscopy for detection of these pathogens. So normally we advise you take 3 slides. One is for KOH, which is for fungal. Other you stain with the gram stain, which will give you the kind of bacteria if they are present. And third is Zimsa, which you can ignore. It's only useful if you want to know about the cytology, what type of cells are there, and probably can help you pick up some of the cases of HSV. The different plates that you inoculate, you need to take 2 plates of blood agar. One is going for anaerobic incubation, another is going for aerobic incubation. Chocolate agar, sabrodextrose and potato dextrose. You can use one or you can use both, and non-nutrient agar. These are the solid plates that you have to inoculate. In addition, we use liquid media and thioglycolate broth. And these liquid media have a specific function. If you are working on, say, PCR-based diagnosis, you can take other suspensions or the corneal scraping for PCR workup. What is the role of liquid media? Why we take, once you are inoculating solid media, why you still want to take liquid media? Any thoughts on this? Primarily what you want, that whenever you are inoculating plates, you are inoculating lot of inhibitors that are present in the cornea at that point of time. Now, if you are putting it only on the solid media, the inhibitors may inhibit the growth, whereas as soon as you put it into liquid media, the inhibitors get diluted and microorganisms start growing. But what is the threat? If you are putting everything only on the liquid media and send that transport medium into the microbiology lab and let them inoculate, why then we are not following that procedure? So there is a risk of contamination and commensals overgrowing the pathogenic bacteria. Therefore, it is important that we include both solid and liquid medium in the workup of our patient. Now, you have clinical diagnosis, you have now microbiological diagnosis. How are you going to treat these patients? And let us begin with this case that I showed you in the differential diagnosis. This was a 35-year-old male presented with the acute onset of red eye of 1 week's duration. He denied any history of trauma, but he had dacryocystitis, which was associated when he presented to us. So what kind of disease are you dealing with? Streptococcus pneumoniae. You are going right into the microbiology, but I think try to understand that unless you follow an algorithm, is it what kind of infection it is? Rapidly progressive suppurative infiltrate. So your all differential diagnosis will come, and then you will narrow down what kind of organism. It is better to think systematically rather than telling strep pneumoniae. Tomorrow if it comes to be staph aureus, isn't it? So always think from the systematic point of view. What is the broad category of the disease? What are possible causes? And then narrow down into the. Now we did gram stain, and gram stain showed gram positive cocci. You are further narrowing down that you are dealing with the gram positive infection. Okay, now how will you manage this patient? Will you give fluoroquinolone or will you start treatment with fortified drops? What will you start treatment with? Fortified. Why fortified? You want to control faster. Let us look at, this is the classical table that gives you what are the antibiotics which have a preferential activity against gram positive, the antibiotics which have preferential activity against gram negative. Cefazolin, vancomycin, which are specific for gram positive bacteria, have certain disadvantages because these drugs are not available commercially. You will have to prepare them and give to your patient. So cefazolin, while we say we can give cefazolin, but the problem is they are not commercially available and the patient will have to come back again and again to collect these. They have a limited shelf life, 5 days or at the most 1 week. Then there are issues when you prepare as far as their tonicity is concerned, pH is concerned, therefore they can cause toxicity. And these are some of the problems with the fortified drop. Whereas fluoroquinolones are commercially available, they have been tested as far as their shelf life is concerned. Usually 1 month is the shelf life. They do not have issues with their storage or the pH or tonicity, and therefore they are non-toxic. So they became popular after publication of this study way back in 1982, where the investigators compared ciprofloxacin with the fortified cefazolin and gentamicin. Now what they found? They found that the monotherapy with ofloxacin was as effective as combination of fortified antibiotics. And that brought the widespread use of fluoroquinolones in the management of corneal infection. Now what was the outcome? Immediately people started noticing that more and more bacteria are becoming resistant to fluoroquinolones. From first generation fluoroquinolones, we moved on to the fourth generation fluoroquinolone, and currently we are seeing that nearly half of organisms which were otherwise susceptible to fluoroquinolones have started becoming resistant. So fluoroquinolones as a monotherapy is rapidly losing as it's the first line of management in the management of corneal infection. So what is recommendation? The recommendation is that if you are dealing with a small localized corneal infiltrate, you can start treatment with the fourth generation fluoroquinolone. First generation fluoroquinolones cannot be considered as a broad spectrum antibiotic. If you are dealing with the case that we started with, then what will be the preferred choice? A combination of fortified drops, fortified cefazolin with gentamicin. We usually want to start treatment with the broad spectrum. You do not want to start treatment with the just gram positive because microscopy may not correlate with the culture results. Once culture results are available, you can then discontinue the antibiotic which is not specific for that pathogen and move to a different antibiotic. Remember that in corneal infection cases, you have to rapidly attain therapeutic concentration, and therefore we advise frequent dosing. Every 1 hour, you can even start every 5 minutes in the office for half an hour and then give 1 hourly doses. You need to monitor these patients closely because bacterial infections are rapidly progressive disease and you may suddenly see the cornea deteriorating or perforating. Once your culture results are available, based on the culture results, you can plan to modify your treatment. Now, what is the role of antibiotic susceptibility? Most laboratory protocols say that we will do antibiotic susceptibility. What is the role? How will you use that information? You must remember that the antibiotic susceptibility results guide us in modifying treatments only if patient is not responding to your primary treatment. There is no need to change your antibiotic just because the antimicrobial susceptibility shows resistance. If your patient is becoming better, continue the same antibiotic and there is no need to change therapy. Why we are saying that? Because in vitro antimicrobial susceptibility tests are based on the serum concentrations achieved on systemic administration of drugs. What you are doing in the management of corneal ulcer, you are putting drops directly on the site of infection. Therefore, concentration achieved in corneal tissues are much, much higher than what you can achieve on systemic administration. So, in vitro test may show resistance, but you have achieved the concentration which are well above that MIC level, and therefore organisms are all killed. And you get cure from infection. So remember that in vitro susceptibility test has its limitation, and we do not have at this point of time any information on ocular concentrations achieved on topical administration. There are certain other principles that you have to follow. Number one, antibiotics should never be tapered. So don't think about starting 1 hourly, then reducing to 6 times per day, then reducing 3 times per day and 2 times per day. That is a wrong protocol. They should be stopped abruptly. The antibiotics have done business, stop them at that level itself. Number two, they continue antibiotic only as long as it is required. As soon as you see infection disappeared, no more bacteria will be alive, and you can safely discontinue antibiotics, and don't wait that surrounding edema should also subside or the patient may get recurrence, therefore I may continue antibiotics. Longer antibiotic may induce toxicity on the cornea, and you may think infection is persisting in the corneal tissue. So what lessons we have learned till now? That you start broad spectrum therapy until culture results are available, discontinue or modify your treatment based on the culture results, and in vitro susceptibility test has its limitation in the management of corneal ulcer. Is that clear? Let us now try to solve this question. Which of the antibiotic will you use in the management of the patient? You will use A, you will use B, C, which one will you use?
Please switch off your microphones, cell phones, or put them on silent mode. All the speakers, Namrata you specifically.
So obvious answer will be the A. A is the antibiotic that you will use. Now what is the role of corticosteroid? You will be seeing that corticosteroid is more and more discussed, and it is not a new debate. People are debating this question in the management of bacterial ulcers right from the time of 1952. So it's a pretty old debate, but we are still struggling to find answer to this question. In 2003, Wilhelmus wrote this meta-analysis, and it showed very clearly that use of corticosteroid in the treatment of corneal ulcers does not offer any advantage. But still, he thought it will be useful if somebody does a prospective randomized trial, which was done in the Arvind Eye Care system. And what were the results? There is no overall difference in the 3 months visual acuity. There are, although no major safety concerns, they said that it may have some role in very severe keratitis. It was not statistically significant. So corticosteroids have very limited value in the management of bacterial corneal ulcer. And if we are practicing in a country where nearly half of ulcers are caused by fungi, I think there is a word of caution that we should exercise when we treat these patients. Let us now switch over to a different entity. See this patient, a 37-year male with the history of 3 weeks duration. So what will be the kind of thought process that you will do or you will use in constructing differential diagnosis? This is a slowly progressive disease, and then you will try to look at what kind of infiltrate it is. It is a cotton wool like infiltrate. You are seeing lot of filamentous extensions into surrounding cornea. So what can be if you further narrow down your diagnosis, more likely to be fungal in etiology. And yes, microbiology also showed presence of fungal filaments on the microscopic examination of potassium hydroxide preparation. This is a chalcofluor white because that helps fluorescence. So how will you treat these patients? There are variety of antifungal drugs that are available. Which one will you choose? Why will you choose? Natamycin you will choose. Why will you choose natamycin? Filamentous fungi. So there is a relative preference in choice of antibiotic when you deal with the candida or yeast versus when you deal with the filamentous fungi. Amphotericin B, fluconazole and voriconazole have good activity against yeast infection, whereas natamycin, itraconazole and voriconazole are good drugs for filamentous fungi. But remember that no one drug is superior to another in this list. You can choose any of these antibiotics. Now there is lot of enthusiasm that has come for the use of voriconazole in the management of corneal ulcer, both yeast as well as filamentous fungi. And this enthusiasm was primarily because the people thought that voriconazole has the broadest spectrum of activity against all the isolates. Number two, most of the trials that were published, they clearly showed that the voriconazole gives better results. But these trials or the publications were mostly in the form of case report or case series. Now, a randomized clinical trial conducted again in the Arvind Eye Care system very clearly showed that natamycin and voriconazole had the similar activity against filamentous fungi in the trial that they conducted. So, the lessons that we have learned from this case are that natamycin and voriconazole are equally effective, and based on their availability and affordability of the patient, you can start treatment with any one of these and then keep the other drugs as alternative therapy. That is, if the patient is not showing response on 2 weeks of treatment with drug A, you can switch over to drug B to give more or give an alternative option. Remember that the treatment of fungal corneal ulcer on medical therapy takes much longer time than in bacterial infection. So you cannot make judgment, my patient is not responding, just by observing patient on day 3 or day 7. You will have to give trial for 2 weeks before you can make the decision, no, this drug is not working. Okay, but you have to constantly watch on the progression. If the disease is continuously progressing in follow-up, obviously the drug A needs change. Some of the other disadvantages with the antifungal therapy are their availability is very erratic. Now we are fortunate that both voriconazole and natamycin are available. They have a poor penetration. Most of these drugs are fungistatic except voriconazole, and treatment failure rates are as high as 40% unless the patient presents very early. Now, what is the implication of this? There are some other techniques that you can use in order to enhance penetration of antifungal drugs into cornea. An intracorneal injection of voriconazole is becoming more and more popular as a mean of introducing drug into the cornea. And the paper by Dr. Namrata Sharma showed that in patients who are otherwise not responding to topical therapy, probably a trial of intracorneal injection of voriconazole can be given, and these patients may respond to medical treatment, and thereby you will be able to avoid surgery in these patients. The other thing that you can do, if your patient is presenting with a raised plaque-like lesion on the cornea, you can excise this plaque. And we showed in a publication in the journal Cornea that these plaques basically comprise of a carpet-like growth on the corneal stroma. So when you do keratectomy or excise these plaques, you are debulking cornea of all the fungal filaments that are present, and then when you give antifungal treatment, it has a better penetration. So you get two advantages of excising these plaques, which enhance the resolution rate in these patients. So let us try to answer this question, which will be the first line of treatment for this case where you are seeing ovoid gram-positive body. So it is basically what kind of infection, filamentous or yeast? It's an yeast. So which drug will be the first drug of choice? Probably amphotericin B, or you can consider using even voriconazole. So amphotericin B will be the other drug. If the alternative is written fluconazole, then fluconazole is commercially available as well. Okay. Let us look at another case which presented to us with the history of 4 weeks illness, had no epithelial defect, had central edema with multiple exudates sticking on the central part of cornea, Descemet family. What is the difference? What will be the diagnosis in this patient? Viral keratitis. Okay. So we made this diagnosis. What treatment will you give? Topical steroid alone or in combination with something? Acyclovir eye ointment. This is what we did. And on day 11, the patient developed epithelial defect, exudates on endothelium regressed, but the edema continued. So you have started treatment with whatever diagnosis you made. In 11 days, you did not get the response that you expected. What will you do at this stage? What will you do? Culture. What is likelihood of that culture will be positive in this patient? And culture for what? Oral antiviral. Fine. So we started oral antiviral, and in 3 weeks' time the patient presented with this clinical picture. What is now your thought process? Secondarily infected. It's not secondarily infected. The corneal scraping at this stage showed multiple acanthamoeba cysts. And acanthamoeba is known to present with a clinical picture mimicking herpes simplex virus keratitis. So the lesson that you can take from this case is that if you start treatment with antivirals and the patient does not respond to antiviral therapy, you should consider differential diagnosis of acanthamoeba. In our country, they account for close to 2% of all culture positive cases of corneal infection. So it is not a very rare entity in our country as well. You should also remember that your classical textbook teaching does not apply to what we see in our clinical scenario. Classical textbook teaching is contact lens is the predisposing factor. And most of the patients of acanthamoeba have disproportionate pain out of proportion to the infiltrate. Now, the other clinical feature which are classically described are a ring-shaped infiltrate and radial keratoneuritis. This is radial keratoneuritis. Now, when we tried to analyze 250 cases of acanthamoeba that were seen at our center, we found some of the very unusual clinical presentations with acanthamoeba. They have been treated as cases of herpes simplex virus epithelial disease, as nummular keratitis mimicking adenoviral keratoconjunctivitis, or frank stromal keratitis again mimicking herpes simplex virus interstitial disease. Some of the patients were having dry raised infiltrate mimicking fungal infection. So when we tried to compile these cases, we found that ring infiltrate was present only in 33% of the patients. A large number of the patients who were presented to us were diffuse infiltrate. The contact lens was predisposing factor only in 3% of the cases. 50% of the patients had trauma as the most important predisposing factor. So how do you diagnose these cases? It is important that we keep a high index of suspicion, specifically in patients presenting with a ring-shaped infiltrate or patients of herpes simplex virus keratitis who are not responding to antiviral therapy in a prescribed period. If you are having any case of otherwise infiltrative keratitis, acanthamoeba should be considered one of the differential diagnoses in patients who are not responding to standard antimicrobial treatment. In these cases, inoculate the specimen on non-nutrient agar and ask your microbiologist to specifically look for acanthamoeba cyst. So in summary, acanthamoeba keratitis has varied presentation. High index of suspicion will go a long way in the management of these cases, and use of appropriate tests will help you confirm the diagnosis. Now, how will you treat these cases? These patients require treatment with antiparasitic drugs, and the drugs that we use are PHMB, polyhexamethylene bigonine, and chlorhexidine. The concentrations are shown here. So they are the mainstay of treatment. In addition, you can treat these patients with propamidine or hexamidine. The unfortunate part is that most of these drugs are not available. Okay, so we treat these patients with PHMB and chlorhexidine, which we procure as a pure solution because it is used as a swimming pool disinfectant. It is also used in various chemical industries as a preservative. So if you get a pure solution, you can keep diluting it and dispense it to the patient. Don't use mouthwash. Mouthwash has multiple other ingredients and it is highly toxic. So don't use mouthwash. Some of the people are using mouthwash as anti-acanthamoeba treatment. Other facts that you have to remember, neomycin, which is described in textbook as a treatment for acanthamoeba, is not effective. It is going to give toxicity. Most of antifungal drugs are also not effective. So don't prescribe antifungal drug as an alternative in the. Number 3 is the duration of treatment is much longer. On an average, each patient of acanthamoeba keratitis required treatment for close to 3 months. So don't panic if your patient is not regressing. He should not worsen. Treatment with antifungal and anti-acanthamoeba drugs should be started only when you have documented these pathogens on microbiology. Don't start empirical treatment for the reason that I just told you, that the treatment is much longer than for antibacterial treatment. Last word about the surgical options in the treatment of, or indications in the treatment of corneal infection. The surgery is indicated only if the patient presents late with a very advanced keratitis, if the clinical picture is unusual and microbiology is not helping you to arrive at a diagnosis, if the keratitis is refractory to medical treatment, even when you have treating based on the culture results, and if the patient shows progressive thinning or perforation. What are different options? The options are corneal biopsy as a diagnostic mean, superficial keratectomy to debulk cornea, tissue adhesive as provide tectonic support, patch graft or penetrating keratoplasty to excise the infected tissue and provide tectonic support. In addition, you may want to use tarsorrhaphy as a mean to protect healing epithelium. And if the patient has a very poor visual acuity or potential, and you do not want to subject them to drastic surgery like keratoplasty, conjunctival hooding still hold a place in the management. So let me conclude this talk by saying that we discussed some of the principles in the management of bacterial corneal ulcer. We also discussed the role of corticosteroid and concluded that corticosteroids have very limited role in the management and should best be avoided whenever you are dealing with the cases of corneal ulcer. We also touched upon the principles in treating fungal and acanthamoeba infection and learned that the antifungal drugs, voriconazole and natamycin, are almost equal in efficacy, and you need not jump on all the time using voriconazole. Natamycin is still hold value, and in acanthamoeba the drugs are not commercially available. You will have to either refer these patients or procure these drugs. And surgical management is indicated in patients who present with advanced keratitis. Thank you very much for your kind attention.
Thank you, Dr. Prashant.